Hello everyone, welcome back to our NABH training series. Today we are discussing one of the most practical and assessment-focused standards in NABH, PSQ.3. This standard is all about identifying, monitoring, analyzing, and improving key performance indicators, also called KPI. Now understand this carefully. You cannot improve what you do not measure. That is why NABH expects hospitals to continuously monitor their performance through indicators. What are key indicators? Let me explain in very simple language. Indicators are measurable parameters that tell us whether the hospital is performing well, whether patient care is safe, whether systems are improving or deteriorating. Think of indicators as the health checkup of the hospital system. Types of indicators. NABH divides indicators into four major areas: clinical indicators, infection control indicators, managerial indicators, patient safety indicators. And today we will understand each one in detail. Clinical indicators. First requirement: hospital must identify and monitor clinical indicators. What are clinical indicators? These indicators measure the quality of patient care. Examples include mortality rate, medication error rate, blood transfusion reactions, surgical complications, anesthesia-related complications, readmission rate. NABH also expects specialty-specific indicators. For example, ICU may monitor ICU mortality, sepsis rate, ventilator complications. OT may monitor surgical site infection, cancellation rate, re-exploration cases. Very important requirement. Every indicator must have numerator, denominator, multiplier. This is extremely important. Infection control indicators. Now coming to a core requirement, infection control indicators. This is one of the most sensitive areas during NABH assessment. Common IPC indicators. NABH expects monitoring of infections such as CAUTI, CLABSI, SSI, VAP. Suppose ICU patients are developing infections frequently. Without indicators, you will never know trend, root cause, improvement status. CDC definitions. One very important point. NABH expects hospitals to use CDC, NHSN definitions for HAI surveillance. This means infection definitions must be standardized. Managerial indicators. Now many hospitals think quality means only clinical indicators. Wrong. NABH also focuses heavily on managerial performance. Examples of managerial indicators: waiting time, bed occupancy, staff satisfaction, patient satisfaction, TUT of diagnostics, availability of records, medication procurement efficiency. If your OPD waiting time is increasing every month, this indicates process inefficiency. Patient safety indicators. Another core area, patient safety indicators. These indicators monitor safety risks. Examples: fall incidents, pressure ulcers, medication errors, sentinel events, near misses, transfusion reactions. Patient safety indicators are not meant to punish staff. They are meant to identify system weaknesses. Data verification. Now let's discuss a very important but commonly ignored area: data verification. Common problem. Many hospitals collect data manually. But when assessor checks source documents, numbers do not match. NABH requirement. Quality team must regularly verify data. Verification can be done through random sampling, source document review, cross-checking registers. If your data is inaccurate, entire KPI system loses credibility. Data analysis. Now this is where real quality improvement begins. Data collection alone has no value. You must analyze trends. What should analysis show? Increasing trend, decreasing trend, benchmark achievement, areas of concern. Example: if falls are increasing for 3 months continuously, you must ask, why? Which area? Which shift? Which patient category? Benchmarking. Hospitals should also develop benchmarks or acceptable quality levels. Quality improvement projects. If benchmark is not achieved consistently, quality improvement project must be initiated. Improvement or evaluation. NABH does not want analysis only. They want improvement, implementation and evaluation. Example: problem: high medication errors. Action taken: staff training, LUSR segregation, double check system. Evaluation: error rate reduced from 8 to 2. If you cannot show measurable outcome, improvement is incomplete. Feedback to staff. Another very important expectation: feedback must be communicated to staff. Why important? Because quality improvement is a team activity. Staff should know current performance, trends, areas needing improvement, methods, dashboard, newsletter, bulletin board, department meetings. Important point. Not only negative feedback, positive achievements should also be shared. Common NC or closure. NC1, indicators not defined properly. Problem, no numerator, denominator. Closure, define formula clearly, standardize methodology. NC2, mandatory indicators not monitored. Closure, include NABH mandated KPI, monitor monthly. NC3, infection indicators not as per CDC definitions. Closure, use NHSN surveillance definitions, train infection control team. NC4, data mismatch during verification. Closure, conduct random audits, validate source data. NC5, data collected but not analyzed. Closure, trend charts, graphical analysis, benchmark comparison. NC6, no evidence of improvement. Closure, CAPR implementation, re-monitor indicators. NC7, staff unaware of KPI performance. Closure, share dashboard, department feedback sessions. NC8, quality projects not initiated despite poor trends. Closure, start QIP, document measurable outcomes. Final summary, always remember, indicators are not numbers for files. They are tools for improvement. A mature hospital does not hide poor indicators. Instead, it uses them to improve systems. In the next video of this NABH training series, we will discuss PSQ.3, quality improvement tools or projects. If you found this session useful, like the video, share with your colleagues, subscribe for more NABH training sessions. This is MediQuality Partners, your trusted NABH guide. Thank you for watching.